Hello, please.
Hello.
Good morning. Yeah, Dr. Burket, do you hear me?
Yes, sure do.
We can hear us.
We have a great case here for you. Dr. Park's going to introduce the patient.
Yes.
Okay. I am Dr. Shin from Gachon University, and this live session will be co-chaired with Dr. Sachar. Yes. I'm sorry. Okay. So also we have we have around 10 expert panelists will join your program together. So please introduce your team and case for the audience.
Yes.
Thank you.
Good morning, everybody. This is the famous Dr. Burket. I'm Dr. Park from Harlem Medical Center. I will introduce the case. A 74-year-old female was referred for the asymptomatic left carotid artery stenosis. Her carotid disease was incidentally found on carotid sound and was intended for routine evaluation. MRA showed a tight stenosis in both carotid bulb and carotid Doppler showed increased peak systolic velocity in left ICA. She has a history of hypertension and DM. She underwent CABG for 3 vessels disease. Okay. Can you show angiogram? Okay.
I don't know, will we be able to show the MRA or is that not available for the audience?
Yeah.
Okay, great.
This is the MRA. You can see the tight stenosis of left ICA, proximal portion, and right ICA. Okay. Please show.
Great. And probably a type 2 plus arch,
Yeah.
bilateral disease.
Yeah.
Maybe we could go next to the first angiogram that we did. So we discussed what the best strategy would be on this case. We talked about proximal protection versus distal protection. I think with the contralateral high-grade stenosis, which when we rotated the MRA, it was pretty clear that the right internal carotid was also very high grade. We thought distal protection may be slightly advantageous over proximal, although I think that would be certainly a valid discussion. And so we thought that we would use a filter device and a sheath in the carotid artery. Maybe we could go to the first angiogram, then selective angiogram. Can you see the selective angiogram at the bifurcation now?
So, any comments for this case?
Hey, Mark, it's Michael Jaff.
Hey, Michael.
Nice case. Tell me why you chose the left versus the right. We don't have we've just had that one view of the MR, but the right internal doesn't look particularly pretty either.
That's correct. I think by MRA they were quite comparable. By duplex, I'm told that the velocities were higher on the left, so we thought we'd go after the more severe one first.
Is this her dominant hemisphere, do you know?
Great question. I did not ask about which is really dominant. By angiography, we took an angio which demonstrates that there is no crossover on the left. So angiographically, the distribution is pretty equal. As far as whether she's right or left dominant, I don't know.
Just a comment regarding proximal protection. We are now using proximal protection as a first-line treatment and never had a problem with contralateral stenosis, so it usually works pretty well.
I think that's a great point, that sometimes when we don't have a choice, when there is severe tortuosity, we can use proximal protection kind of cringing with the contralateral occlusion or high-grade stenosis, and it turns out that patients tolerate that quite well. So I think that's certainly a valid point. In this case, what we opted to do is to place a NAV6 device. Perhaps we can show a replay that demonstrates first our, let's go to the next image. Are you able to see the in-lab angios there?
We see the DSA. Yeah.
Okay, so here's a selective, we went in with a VTK catheter, and if we can go to the next run, please. Here you can see our cerebral circulation, middle and anterior cerebral with no crossover really. I think you can skip the lateral view and then go to the next view after the lateral cerebral shot. Okay, you can go to the next one. So first we crossed with the NAV6 wire. As you know, it's an independent wire system. Then the next shot, so that's the, actually that's our wire in the external, which we use to put the shuttle up. You can continue to go forward. Then a shot through the shuttle sheath. I like to do this non-subtracted just so I have a good feel for where the lesion is. And then we try not to move the table. Next shot, please. Initially, we tried to get the NAV6 wire in. It just wouldn't cross, so we put a more sweeping curve on it, and that passed easily. Next shot. Then you can see the NAV6 filter deployed there over the mandible. So we're deployed, and she's anticoagulated with therapeutic ACT. And now we're just getting ready to bring the balloon up to the target lesion.
Mark, as you do that and get the balloon up there, great case. In the U.S., we're limited in terms of what filters we use or stents we use, or whether, in fact, we do carotid stenting at all based on trials and CMS and reimbursement. But a question for you and for the panel, if all else being equal, is there any particular filter, distal filter, you would prefer over another, or you base it just on what's available at the time?
I think there are a lot of good choices that are available right now. I like an independent wire. The ability to cross with a wire prior to introducing the filter. So I like the NAV6. We also can use a spider in that setting. We're going to bring our balloon. I think you can see that the balloon right now is just about across the lesion. So we're going to inflate. And what I like to do is to
So what is the balloon size here?
I beg your pardon?
What is the balloon size?
This is a 4 by 2.
And how do you determine the balloon size?
I typically will predilate with a 4 pretty much in any standard sized carotid. I think we're just coming, and I very often will use a 4 by 3 so that it doesn't slide off the lesion.
We are more and more using the final balloon diameter for predilatation as well. What do you think about that approach?
You know, I kind of use the initial balloon as a way to size the vessel, so I tend to underestimate that just a little bit. Now, she started out with a resting pulse of 48. We're now inflated to 8 atmospheres, and she's 39 with a blood pressure of 140. So I think she tolerated that quite well. And I think with the change in the anatomy here, with the balloon in place, we'll take another angio. With the balloon in place, it's going to help us to be oriented during the procedure.
There was a question about atropine, if you've pre-treated with atropine, or if you're thinking about that at this point.
So we had that very discussion just before. I think we'll hit this one more time. Go up there to 6, please. We had that discussion.
6?
Yeah.
Yeah.
We had that discussion here in the lab to pre-treat or not. Now, we typically do not in our lab. You can go to 8.
6. 8?
8.
Yes.
Come on down. Yeah. And then we'll take the stent.
Do you routinely predilate the lesion before stenting?
Yeah, I routinely predilate. You can come down.
Yeah.
Come down. I routinely predilate. I do not routinely give atropine. I think especially in this case where her resting pulse was 48, we might be more inclined to give it, but I think the dry mouth that they get sometimes makes some slurring of the speech, and sometimes we're just confused about whether that represents a neurologic finding or an atropine effect. And she tolerated that pretty well, I think.
How long, usually how long did you inflate a balloon?
Just long enough to
take.
take.
The balloon time is correlated with kind
Stent?
of a bradycardia,
Stent,
right?
yeah. Stent.
Stand.
No, 9:30 wall. Yeah. So basically, I usually inflate long enough to take a picture. Typically, what I'll try to do is I'll try to inflate to the point where I get kind of a dog bone appearance or a dumbbell appearance. And once I have that, then I inflate, and I take a picture of that. Then I fully inflate, typically at least to nominal, and take a picture there and store that, which helps me to know whether I want to upsize my post-dilatation balloon or not. And then we'll go with the stent. So in this case, it'd be interesting to, I'd be curious to see on the panel what choice of stent you may select.
Can we see the angio after predilatation?
Yes, can we replay that, please? Great. We need to flush this.
플래시했죠? 아니,
Let me just flush. It'll do one more flush here. Great. Can we replay the angio after balloon inflation with the balloon still in place, please? We should have that angio up for you there.
This is much bigger now. Is that a different magnification or?
I understand that this is after first predilatation, the balloon was too high. And did you take another one after
Yeah,
the second
then we
predilatation?
brought the balloon down a little bit after we did one more inflation after that, again to nominal. And you can see there's kind of a intravertebral space there that I think would probably be a good place to put the distal portion of the stent, kind of just around the curve a little bit there.
So any thoughts from the panel on open cell design, closed cell design, or other thoughts around stent choice? So Sievert, what would your choice of stent be here?
Well, it's actually a little bit banded, so I think it doesn't make a big difference here. Probably I would use a more flexible stent here, like Cordis or what is this one?
So this is a carotid wall stent.
Wall stent.
Yeah, and I chose that because of the nature of the curve. Here, I just thought that my sense is that the carotid wall might kind of smooth that out a little bit more.
Well, I think the carotid wall stent is very flexible as long as it is mounted on the delivery system, but later on it's sometimes a little bit stiff. But I mean, this is a straight vessel, so in any case you can use all stents. What is the diameter, the fully open diameter of this stent?
930.
930.
Do you have any other specific indicators when you decide which kind of stent, for instance, the open cell or closed cell, except the vessel angulation?
We're going to post highlight that 4 again.
Any other indicator to decide which kind of stent?
4짜리 볼륨 가시죠.
Well, I think flexibility of the stent is the major issue. So closed cell, open cell, I don't think it makes any difference.
That and calcification, radial force.
Radial force.
Balance the two issues. There is some calcification over here. I think the wall stent's a good idea here. You get it.
Yeah, so there's kind of mild calcification, certainly not severe. And there was just enough tortuosity that I thought that the wall would kind of smooth that out. But I think any stent here would probably perform pretty well, as you pointed out. It's not a particularly tough lesion. And although there is a big bend at the lesion, there is not excessive tortuosity distal to that point. How about post-dilatation? Should we bother?
Yeah, I think with the wall stent, most often you have to post-dilate. We are using, as I said earlier, we're using bigger balloons initially now, and then we usually don't post-dilate. But with the wall stent, the self-expanding force is usually not enough.
Post-dilation does pose a higher risk of stroke, but in this case, you have a waist, risk of restenosis may be higher. I think probably a good idea.
Mark, it must be fun for you to do this case since you couldn't do this case today in the United States
That's
unless
right.
the patient paid on their own.
Yeah, exactly. You know, virtually everyone is a Medicare patient who is 74 years of age. And so unless, occasionally we have these discussions in the office where the patient would say, well, what would you want done? And if I say stent, sometimes they'll bankroll a stent, but that's not very common. Usually our therapy has had to change, unfortunately.
How did she tolerate that in terms of her hemodynamics?
So her blood pressure dropped to 100 with that, and her heart rate 43, and she's very stable clinically, so I'm just going to let her ride that out. I chose to use the same balloon to post-dilate as to pre-dilate. You can see that there's been some recoil there. My thought is, if you look at the distal ICA, the diameter in the distal ICA is considerably smaller than the area in which we're working. And so I have that in mind as I'm going for what to get post-procedure. And in addition, as you mentioned, sometimes your highest risk of stroke is right now. So I think the overall rate of restenosis will certainly be acceptable, and it's worthwhile avoiding a stroke at all costs.
Now, Gore has a new stent out, the scaffold, which has a mesh around the nitinol portion, presumably to reduce the risk of distal embolization. Any thoughts, Mark, regarding that, or from the panel, whether that's needed?
I think to some degree it depends on the lesion. So certainly the more unstable the lesion, the more likely it is to have unstable plaque or thrombus, the more I'd like to have something just like that. So you can see we've got pretty good flow. We have good apposition of the stent with the common. We have not propagated the kink distally, which is one of my concerns. So I think we're good to recapture. Everybody agree with that?
Yeah. Looks good.
Any thoughts from the panel on the dye going into the interstitial space behind the stent?
Well, that's pretty typical for the wall stent, so it doesn't really matter.
Yeah, the wall stent really kind of straightens out curves. It's interesting to do a comparison of a nitinol stent to the wall stent. You'll see that the nitinol stents tend to hug the wall and conform more to it, and the wall stent tends to smooth things out, as you can imagine just when you consider the architecture of it, that it's a woven wire stent that can't really go all the way out to the vessel wall. So I think that's right. This is a very typical wall stent appearance.
I mean, the result looks good. In retrospect, it would have been an option to place the stent a little bit lower.
Yeah, I think that's right.
Result is still good.
Yeah. So I'm always cautious at that step right there, bringing the recapture device right into the stent. So we'll hold the recapture device there and draw the wire back, which then pins the NAV6, collapses it, and then at this point also we want to bring it back very slowly to make sure that we're not snagging on the stent.
This lesion looked very hard, so residual stents after stenting looked more than around 40 or 45%. So what is the guideline of the residual stents after carotid stenting? Do you have any idea or comments?
Some residual is not bad. In fact, from the capture data,
let's do a cerebral shot. So let's go AP cranial, subtracted.
Residual stenosis of 0% from the capture data was actually associated with an increased risk of stroke, suggesting a more aggressive approach is more riskier. I think 20% is fine. I'd love to hear from the panel. even 30%, I think, should be okay, rather than aggressively trying to post-dilate and increase the risk.
All the way up over the brain?
Yeah.
Yeah, I think you have to remember, those of you who are doing this, that you're doing this to prevent artery-to-artery embolus, not flow-related ischemia. So I actually don't think you have to go the distance to make it look perfect.
So do you always do a post-procedural angiogram?
You know, it depends on the patient. I think if we are in a protocol that requires it, we always do. If the patient has renal insufficiency, I always don't, if I can avoid it. And so I think in this case, to do a single AP cranial kind of reassures me that the cerebral flow is okay. But I think that in a straightforward case, it's not mandatory. Could we look back? I just want to make sure that we've seen the stent adequately and we don't need to repeat that. Could we go to the preceding run? I think if that looks good, then we'll just get this sheath out of here. Yeah, I'm not concerned at all there, so I think we'll go ahead and get the sheath out. If we could have the wire that we first used, the J wire, and then we'll back the sheath out. So her pressure is still low. It's 100. Would any of you feel, and she's stable clinically, her heart rate is 52. Would any of you feel obligated to give her either atropine or to put her on a pressor at this point?
Well, fluids for sure, but pressors probably not, or definitely not.
Yeah, I'm quite comfortable not doing that. So, and then one other thing, which I think is kind of a small point, but it might be worth discussing, just the small point of when removing the sheath, I'm always reluctant to just pull that back out of the carotid, because as the tip kind of whips out of the common carotid, I'm always afraid that I'm going to scrape the common carotid artery. Do you think I'm being paranoid with that, or is that something that others do?
I routinely do that. I think it's a great idea to do that, especially over here you've got a type 2 plus arch, as you had said, and more of an angulation as you pull that out.
Great. Okay, we'll go ahead and switch to
Yes, we prepared the sheath.
And that's a 7.
Oh,
Good.
Yeah.
So I think we're just about wrapped up here. I think the team has done a fabulous job of making this smooth here today. We're going to swap the sheath out and then manage the groin, and I think we'll be done.
Okay, Dr. Burket, Dr. Gao is waiting for us next door. So
wonderful.
We can come back after finishing your procedure.
Wonderful, thank you.
Okay, thank you.
Great case.
Okay,
Dr. Gao.
yes.
Good morning, I'm Dr. Hsien.
Professor Hsien, good morning.
Okay, thank you so much for waiting for us for a long time.
No problem, no problem.
Yeah,
we are
okay,
chatting
please,
here.
introduce the case and your team together, okay.
Yeah, today I'm working with my old friend, Professor Rhee here. So I'll let him introduce the case for you.
Yeah. This patient is a 70-year-old man admitted for treatment of asymptomatic severe stenosis on right carotid artery. He had a history of stomach lymphoma 5 years ago, and he underwent chemotherapy, and the disease is stable. And during the routine follow-up CT angiogram, right, proximal IC stenosis was visible 5 years ago, moderate stenosis, but it was slowly progressed, and from 1 year ago, the region was very tight, so he admitted to treat the region.
Yeah, so the history is very interesting. Actually, this gentleman had no atherosclerotic risk factors except for the age and sex. He had a repeated neck CT for the follow-up of his B-cell lymphoma, which is in complete remission now. But then, incidentally, the carotid stenosis was picked up and confirmed not only by the CT only, but also by the neck ultrasound. The PSV is very high. So he's totally asymptomatic, but the lesion is tight, so I think that the treatment is indicated. Can we have the first angio today?
Yeah, this is the left side.
Okay. So this is the angio, the left carotid injection. Left side is normal, except for some distal tortuosity. Intracranially, the vessel on the left side is also okay. And the right A2, A1 is actually perfused by the left side, meaning that the stenosis on the right side must be very tight. Next one. And this is the non-selective nominal injection. Because this patient also had a type 2 plus arch, so it's quite difficult to engage into the common. Usually I use a GR4, but in this case I cannot. So it's a VTK first, non-selective. And you can see from this injection already the stenosis on the internal carotid artery. Next one. And then with this, we use a stiff type Terumo wire to go inside the ECA. And then with a bit difficulty, we can advance the VTK into the common carotid. So this is a stored live fluoro. Okay. Next. So a selective carotid injection can tell us how tight the stenosis actually is. Next one. Intracranial vessels are okay, but A2 cannot be seen. This is a lateral projection. Next one. And this is a lateral visualization of the lesion. So, no, let's stop here. So, can I ask for your advice on this case? What kind of protection device would you want to use in this gentleman?
Dr. Gao, we have expert panels, so please ask us. Panels.
Yeah.
Any comments? Yes.
So it looks straightforward. We, as I mentioned earlier, we almost always use proximal protection, but any filter would also work here. I think it's a short lesion. Shouldn't be a problem to use any other device as well.
Yeah. I think the concern here is that from the CT, the plaque actually is very soft and ulcerative, actually. From the angio, it doesn't look like very ugly, but still we want to use a proximal device here. So, like I had mentioned earlier, the arch is a bit difficult. So, with the VTK in place, next one?
Yeah.
We use the stiff type Terumo to go inside the ECA again, advance the VTK into the ECA also, and then exchange it into a stiff type M-Plus wire. And over the wire, we can advance a French MoMA device. So this is the advancement of the MoMA. And
so why did you use 8 French and not 9 French?
Oh, I'm sorry, 9 French.
Yeah, this is 9
French. I'm sorry,
9 French MoMA device.
Yeah.
8 French.
So this is the intended position of our distal and the proximal balloons. So after inflation of the external balloon, we can see now the external is blocked except for the very early superior thyroid branch. But the vessel looks a bit small. We have tried to pull this system back, but then if the system is pulled back, once we inflate the ECA balloon, it will tend to fall back into the bifurcation area. So we had to park our distal balloon here. And then...
do you think that's the patient at risk having that branch open, or do you think that's acceptable?
Well, I think we are running a bit risk of having an embolization from the superior thyroid. But like I had explained earlier, I cannot move the system back without losing my position, because you can see the branch is so proximal. So if I pull back the system, once the ECA balloon is inflated, actually we have tried this, and then the balloon will squeeze itself out and backward into the bifurcation area and obscuring part of the internal ostium. So we have to start in this position.
But so the point is, as long as you have no reflux coming from that artery, it's fine.
Yeah.
But if you have reflux, then you don't have any protection at all.
Yeah.
And that's why we always test whether we have reflux or not. That means we inflate both balloons, do an injection, and observe the contrast in the internal carotid artery, whether it stays there. If it is washed out, that means there's influx coming from
Yeah, that is exactly what we will do. So we have chosen a Sion wire, and the wire is ready for crossing. So at this moment, we can start clamping, see if we have filling into the internal from the superior thyroid. If that's not the case, then we will proceed with the procedure. Is that okay?
Yes.
Okay. So you don't care of a small STA?
Well, we will check for any...
Put them first.
Oh, yeah. We have to clamp first.
Yeah. Okay. Can you see the pressure? Pressure 좀
Yeah,
보여줘요.
the pressure now is coming
pressure,
down.
pressure, pressure.
So we
좀
can do
보여줘요.
a small test here to see if we have
Okay,
a.
we already use a large amount of saline. Okay, okay.
Okay.
Yeah, please show us the occlusion pressure once again.
Right, we are doing a small test here
Okay,
to see whether the contrast is.
okay.
Okay, so you can see the contrast is hanging there. It's not being flushed downward. So I think the STA is probably insignificant.
Timer.
Okay?
Yeah, looks good.
Stump pressure is around 70, so I think we are fine.
Stent.
So the high stump pressure is the reason why you don't have flow coming from the suprothyroid artery.
Yeah.
That's a key.
What type of anticoagulation are you using? Is this heparin or?
Just heparin, 6,000 units. So given according to the body weight of the patient.
Any thoughts from the panel or from you, doctor, about bivalirudin for carotid artery stenting? Any benefits or just increased cost?
We just use heparin.
So this is direct stenting without predilatation.
Which type of stent?
It's a carotid wall stent 9x30.
So you don't routinely do the predilatation?
No, because I think carotid wall stent is a very good one.
6-0.
With a very tight lesion, it will cross most of the time. And especially if we are using occlusive type of protection, you really want to save the procedure time and also minimize the ischemic time.
So you don't use any flow reversal technique, just clamping.
Just clamping, just clamping.
Mm-hmm. You know, Paul makes this look so easy, but I have to tell you, there's a pretty large cohort, at least in the United States, who feels strongly that this patient is just as effectively, if not more effectively, managed medically, and is a perfect enrolled candidate for a number of trials around the world, CREST-2, ACST2, SPACE-2. So we'll have to see, but the jury's still out on this.
We will do a post-dilatation here. Let's go to 6. Down. The balloon is moved backward. Now, 4.
This is 6-0.
6. 6x20. 4.
2, 4.
6.
6. Blood
8.
pressure is on 60.
Okay, down.
8. Down.
The blood pressure is 160
Heart
now.
rate is
Heart rate is what?
120.
46, 48. Okay.
Okay, no problem.
The lesion was beyond the bulb, so you don't have too much of a response here.
Yeah. Systolic blood pressure is around 100. 환자분 왼손 찍찍 해보세요. 오른손.
Patient is actually doing fine. So I think we can do the aspiration now.
Yeah. 여기 좀 보여줘요, 테이블. 테이블 좀 보여줘요.
Today we are using an extra large syringe.
60.
Usually we don't need that much. I will just take 15 for the first one. And also, we don't want to aspirate too forcefully.
So you aspirate twice or 3 times?
Yeah, we will check the second syringe for any debris. If that's the case, we will do further. If no debris in the second syringe, I will just release the clamp.
The people in the back have a mask and you don't have one. Is there science behind that, or is it just by chance?
Just by chance.
Dr. Gao, what percentage of your patient intolerable to proximal protection in general?
No, I think, well, it's about 10-15%. But by intolerance, sometimes if you can keep your ischemic time very short, even though the patient starts to yawn or become drowsy or dizzy, but as long as you can get the job done quickly and release the clamping, patient will come back. So the true intolerance, I mean, you had to stop the clamping. So do we have any?
Nothing.
Okay, we have nothing.
Yeah.
So I think with the direct stenting, we minimize the risk and the volume of the occlusion. I mean, the debris. So I will release the ECA first.
Yeah. 프레셔 보여줘요, 프레셔.
Okay.
프레셔 좀 보여줘요, 지금. 프레셔 좀 바꿔줘요.
The stump pressure is still very low now, huh? So I will
카메라로
release the
돌려봐요.
proximal now.
Okay. Pressure will be same after deflation. Okay.
Yeah. So for this particular patient, actually occluding the external probably is not necessary because you can see the pressure is still very low.
Total
Now-
occlusion time is about 5 minutes.
5 minutes.
Yeah.
5 minutes to be exact.
Okay, I will.
Okay,
remove-
so we're ready to
I
take
will
the final
remove
shot here.
Contrast already removed here. Okay, again. Okay, okay. Okay, angiogram.
Okay,
Ready?
ready. Okay.
Visual.
That looks nice to
Intracranial?
me. Let's take an intracranial shot. Okay,
Okay. Wait.
I'm sorry.
Okay, angiogram.
Yeah.
AC is still invisible.
Okay, still we don't see A2. Okay. But anyway, I think the MCA territory, we don't see any cutoff. Patient is
Have
fine.
you ever
clinically.
seen?
Yep.
Have you ever seen an embolic event in a patient who did not develop symptoms?
Yes. Because sometimes the symptom develops a bit slow. So on the spot, maybe the patient is fine, but in 2-3 minutes later,
angiogram. 머리
sometimes
움직이지
the
마세요,
symptom
환자분.
develops.
Okay, no problem.
Looks very good.
No. My question was: have you seen emboli on the angiogram in a patient who did not have symptoms at that time?
Yeah, well, like I had explained, sometimes, because right after the procedure, we will do the angio. And there are, several cases of mine where we detected an emboli, but at the moment of the angio, patient is still fine. But then 2-3 minutes later, patient starts to become a little bit symptomatic.
Can I take the wire?
Just in case you find out that this embolization, what do you prefer to have a medical treatment or direct neuro intervention?
Well, usually we will give a very local and also focal application of drugs, such as some additional bolus of heparin. And also we can try to wire across. Sometimes the mechanical movement will dissipate the clot into a distal smaller branch so that the neurological sequel will be minimized.
In this situation, in the case of have medical treatments, multiple distal embolization. In that situation, when you use heparin, in that situation, some kind of a hemorrhage transformation happens. So, I think mechanical extraction of the thrombi or the plaque debris. But in that situation, I have a question that the interventionist as a cardiologist, we should have a trained to do something intracranially.
Yeah, that's right. For some neurovascular salvage procedures,
This comes up quite often. The risk, I'd love to get the panel's thoughts on this, but the risk of a large embolus that's going to be in the M1 or M2 territory that you can actually go after is very, very low. And almost always it's going to be a distal embolic event in the M3, M4 territory where you're not going to intervene anyway. I can't remember the last time we had an embolic event with carotid stenting, which was something that would be retrievable. So I'm not really sure even that's a...
well, but personally, I have probably 10, 12 cases experience where you have a relatively distal emboli, maybe M2, but sometimes this can give patient a very dense neurological defect, such as aphasia, especially it's happening on the left side. And with that kind of situation, if you just treat the patient clinically, conservatively, the patient will still suffer from this and cause the decrease of his daily life quality. So with those kind of cases, we can still use a coronary wire and a microcatheter and try to do some maneuvers like I have mentioned. A very focal, small dose heparin, sometimes nitroglycerin to release some of the spasm so that the clot can move more distally. We also have several experiences of even balloon angioplasty for a very distal M2, beyond M2 emboli. And these patients can be salvaged, so the neurological deficit will become recovered, at least partially.
And Dr. Gao,
Yeah.
When you have, prepare to do the something in the carotid artery, and then incidentally you find out some intracranial aneurysm. So in this situation, the aneurysm treatment is first, or carotid treatment is first?
Well, nowadays, because all my patients, I will have a pre-procedural CT angio. So usually it's not going to happen. If before the actual treatment, we did find some distal intracranial aneurysm, we will size the aneurysm. If it's larger than 5 millimeter, then of course we will have the neural interventionist to coil it first if they want to do this. Or the other hand is that we can do this in a simultaneous session, so that we stent the carotid first, and then the neural interventionists come in and do the intracranial coiling at the same stage. Because sometimes the carotid stenosis is just too tight for them to do intracranial coiling.
And then does that the carotid stenting give a bad effect to the aneurysmal?
That is, in theory, that is possible.
Expansion of the aneurysm.
Yeah, that is in theory possible. But for those cases, usually we will sedate the patient and then control the blood pressure very carefully. So keep the blood pressure as low as possible.
Check the final angiogram.
Yeah. Okay. So I think angiographically and clinically, this procedure is successful, and I think it's done.
Okay.
Okay.
Thank you very much.
Thank you.
Very well done.